Okay, well, this morning we'll talk about the benign lesions in the cervix. The cervix is very commonly examined because we have the pap smear and so forth, and so we have often sampled the cervix, and so we know a lot of the benign lesions. Some of them are common, and some of them are rare. This picture shows something that is rare in Vietnam, but common in many parts of the United States. Snow. Snow on the fence. Oops. Yeah, snow right here. So maybe some of the things we will talk about are rare in the United States, but common here, or uncommon here and common in the United States. We'll have to see. As usual, our goal is to help you to recognize things so that you can make the diagnosis, and especially in recognizing benign things so you don't confuse them with malignancy, and then tell them apart. How to report or how to improve processes, we hope also will be part. So the benign lesions in the cervix fall into several different categories. Metaplasia is change from one epithelium to a different type. Displacements, so tissue that is normal in one area but in an unusual location deep in the tissue. Ectopias, heterotopias. We've seen these in other places. Pancreas in the esophagus, stomach in the upper esophagus, and so forth. It happens here as well. And then hyperplasia, exuberant growth beyond what is normal. We may get a little bit into some of these others. Some of these will probably wait for next time. The most common lesion in the cervix is what some people might even think of as normal. Squamous metaplasia, the change of this glandular tissue into a squamous tissue. Now, in some settings, this can be a difficult diagnosis. If it is immature or a little atypical, it can look like cancer or CIN. Yeah. And especially if it's very pronounced and extensive, it can be something we have to study. In other situations, it can be very easy. Mature. Mature. Yeah. Yeah. And this word florid, florid means extensive, very growing. Florid means like a flower. It's growing. Typically, with this process, you'll see some remnant of a lumen or some remnant of columnar epithelium on some surface, but you may have totally solid nests, and you will probably have inflammation associated with it as well. Not a hard diagnosis, but very common. This is something that also is not highly common, but you should see this now and then, maybe once a year or twice a year. Transitional type of epithelium can be found in the cervix, in the transition zone, and sometimes looks like metaplasia, but actually will have a different phenotype and be true transitional epithelium. Now on Pap smear, this looks very different than dysplasia, so it's not a hard thing there. But on a biopsy, it can look very much like high-grade SIL or maybe atrophy or something like that. So it can be more difficult to make this diagnosis then. A helpful feature is that these nuclei are different. They have little grooves in many of them. This phenotype may also be helpful, but these are not common markers in many laboratories. So here is an example. You can see why this might be confused with high-grade SIL. There's no maturation. But if you look closely, you see some of these nuclei have little grooves in the little lines in the nuclei that can suggest this is not a squamous cell, this is a transitional type epithelium. They also tend to have this streaming appearance, which is helpful. So this is what was inside the windows we looked at earlier, by the way. The other feature for transitional neoplasia is that these markers will be different. So sometimes you can do different cytokeratins to make this diagnosis. Or what I usually do is I will do markers for SIL, P16, Ki67. They will not be expressed in this region. Tubal metaplasia and tuboendometrial type of metaplasia can also occur very commonly in the endocervix. And sometimes this is a problem on our Pap smears. We see these cells, they look atypical. The nuclei have coarse, thick nuclear membranes, and they may have nucleoli. The NC ratio is disturbed. So these can be confusing on Pap smear. But the glands are usually the same size as endocervical glands. On the biopsy, they're not usually a problem. However, some of these cells can be P16 positive. It's a here a cell, there a cell, not everywhere kind of pattern. So it's not highly suggestive, but if you don't know the pattern, it can be confusing. And to complicate things, not too long ago, someone reported an adenocarcinoma in situ that had cilia. So that can make, I used to say, if you see cilia, it's benign. I can't say that now. So here's an example. You see small, medium-sized glands and a slightly darker columnar lining. Maybe a little stratified here and there, and some irregular shapes. So sometimes this can raise concern for adenocarcinoma in situ. And at higher magnification, we see that these nuclei, some of them are quite big, the chromatin is a little coarse, and they tend to pile up a little bit. So they look different than normal endocervix. If we find cilia, that helps us to say, oh, ciliated metaplasia. You can also get endometrial type epithelium mixed in with this at times. So it actually looks like endometrium and tube. That's usually in the higher endocervix where that occurs. Here's another example of sort of tube and endometrial type of metaplasia here, this sort of process. There is a mixture of ciliated and non-ciliated cells in these biopsies as well. So just being aware that metaplasia with endometrial or fallopian tube type of epithelium can happen is useful. Endometriosis is usually an incidental finding. Most of the time this is post-delivery or some other surgical procedure because it's probably traumatically implanted. And usually it's just an incidental finding, very localized, insignificant. But occasionally it'll be a mass, or occasionally it will be biopsied at colposcopy because it looks different to the colposcopist. The key to this is oftentimes identifying the stromal cells. The epithelium can look atypical and raise concern for adenocarcinoma in situ. But if we have a CD10 positive stroma, that tells us endometrial type stroma, not cervical stroma, not adenocarcinoma in situ. Once again, however, P16 sometimes is expressed in endometrial tissue and can make it difficult to distinguish adenocarcinoma from other possibilities. So don't just do that stain if endometriosis is a possibility. So here we see some superficial examples of endometriosis, normal endocervical glands here, and you see these are darker, a little more closely spaced, taller cells. Could it be dysplasia or carcinoma? And you also begin to say, well, maybe the stroma is a little different. More hemorrhage, more spindle-shaped cells. This will be CD10 positive almost always. But you can see how, these taller columnar cells could raise a little concern for adenocarcinoma in situ. There is an entity which is termed endometriosis or adenomyosis with sparse glands. So essentially, it's primarily stroma and not very many or rare glands or no glands. It can be very hemorrhagic, look like maybe stromal sarcoma or other possibilities. Even in some situations so hemorrhagic that people wonder about a vascular sarcoma like Papacy's sarcoma. So this is a rare finding of stroma-only endometriosis, but it is reported. This is a new word, endocervicosis. Not very many people in American pathology can say this word. So endocervicosis is sort of like adenomyosis in the corpus or salpingitis ischica nodosa. This is a displacement. So normal endocervical mucosa, deeper in the tissue than normally you would expect. But again, the differential then becomes, is it an invasive, well-differentiated cancer? And the key to that is seeing some portion of stroma with it. Also, there will not be any atypia in the overlying surface. So that's important. With adenocarcinoma in situ and early invasive, there should be a surface atypia to go along with the deep atypia. So here's an example. Surface would be way up here, and way deep down into the cervical stroma are these glands. They're fairly benign looking, normal endocervical epithelium. But if you've got tubal metaplasia or you've got other changes on this, it could become more concerning. Here's an example. Again, the stroma can be very useful, and it's a little different than the surrounding fibromuscular tissue. So let's go on and talk about tunnel clusters, which is a special term for a particular type of glandular structure in the cervix. These come in two types, those that are cystic and non-cystic, and are usually present only after multiple births. So it's not usually present in a nulliparous patient. There's usually this lobular configuration and no atypia. So it's not hard to say, oh, that's benign. This is the name for, oh, that's something that's benign. But occasionally we can see mitoses. So here's an example of a more cystic type, dilated. And you see they have this lobulated structure. They're closely packed together. So that can sometimes raise concern for cancer because they're close to each other. Here are some examples of the non-dilated types. A cluster of glands, as you see here, minimal dilatation, but they can also have a little bit of atypia. It's more of a degenerative type atypia, not very much real high-grade type of atypia, but could raise some concern. Microglandular hyperplasia is a very common lesion, and this is in hormonally active women. There's usually some sort of hormonal stimulation and then maybe a drop. So it could be thought to be similar to the Ariostella reaction in the cervix. But patients who have been on oral contraceptives and stop, or patients who have been pregnant and then are no longer, can oftentimes be the presentation. The glands are close together, and there's usually this mucus and inflammatory process with that. Because of the closely packed nature, we can sometimes be concerned about endometrial carcinoma or endocervical carcinoma, rarely clear cell carcinoma if there's atypia. So here's a classic appearance, normal endocervical epithelium, and then closely packed lesion, dense glands, and a very mixed inflammatory pattern inside the lumen of many of these glands, and some vacuolization to the cells. Here we see a higher magnification. You see all of these subnuclear vacuoles. It's like the subnuclear vacuoles in the endometrium just after ovulation. So there's this hormonal change, I think, triggers the vacuolar change in these. Here's some of the patterns, a more solid pattern. Here's more stroma in between, and here's a more myxoid, with some atypia in this particular case here. This is not usually a problem to distinguish from carcinoma, but when it was first described, people were concerned that it might be a precursor lesion for adenocarcinoma. This entity, diffuse laminar endocervical hyperplasia, is also in the reproductive years, but rather rare. In this situation, you have a very sharply defined, fully circumferential region of the endocervix that is hyperplastic. And there can be some atypia, so sometimes concern about well-differentiated carcinoma is raised. So here is something that represents this. You see a very sharp boundary at the deep portion, very highly packed hyperplastic glands, maybe with a little bit of inflammation. So diffuse laminar hyperplasia, this would be extending perhaps over several millimeters, maybe a centimeter or more in the endocervical canal. The last hyperplasia of significance is lobular endocervical hyperplasia. And this is important because it also can be responsible for abnormalities on the pap smear with some atypia in the glands. They also can have this cribriform change or even a pyloric metaplastic appearance in some of the glands, even to the point of having true more gastric or pyloric phenotype with gastric type mucus and negative estrogen markers. So here's an example, a central duct with surrounding lobular hyperplastic glands. And as we look at the next one, you see a dilated gland with surrounding non-dilated. And here this much more exuberant, more pyloric or Brunner's gland type appearance to some of the epithelium. Again, this is rare, but knowing that it exists may help. Mesonephric remnants are a very common finding, up to 10%, although again, I think this may be often overlooked or not sampled. When we sample the cervix in our laboratory, it's usually anterior and posterior. If we sampled right and left, laterally, we probably find this more often than this. Now these cells can be P16 positive as well. So that is a potential pitfall for adenocarcinoma if we just rely on the stains. And oftentimes there will be some little remnant of a larger duct. We'll usually see this central secretion. There's no stromal reaction and no surface connection in most cases. So here's one with a central duct, and we see these small inconspicuous glands with a few of them having a bright pink secretion. This is mesonephric remnant with some hyperplasia. Now we say hyperplasia, but they're not really mitotically active, so we could just say prominent mesonephric remnants. Here's a high magnification. Again, you see the PAS positive secretion. And these are very low cuboidal cells, very bland appearing, but they're in an odd location that can raise concern. Higher magnification, you see somewhat clear cytoplasm and again, luminal secretion. So, concern for well-differentiated carcinoma in a deeply placed lesion is understandable, but once you know the lesion, you quickly can dismiss that possibility. On occasion, the ductile elements can become quite hyperplastic and quite atypical. So here we see, this is in a deep location, similar to this type of a situation. But as you see, not just low cuboidal cells, these are more columnar. There's some cribriforming architecture. So this looks a little more concerning for cancer. And so therefore we can become very concerned about the possibility, and misdiagnosis is a real possibility. So things that would favor this being a duct would be some sort of an elongated duct. The presence of these very small micropapillae, like this, favors this mesonephric duct. And absence of nuclear atypia, although in here I think there is some nuclear atypia. The other feature is no connection to the endocervical glands. Isolated deep finding that looks like this, no surface abnormality, is going to be benign, not isolated adenocarcinoma.